I would like to welcome everybody this evening to this session where we're going to go through the topic of early in your thyroid cancer journey. What happens in the beginning. This is focused on differentiated thyroid cancer, so papillary and follicular. And we're going to talk about kind of leading up to the diagnosis. Where do you go from there? Early in the journey type situations. So just to run through the agenda and the format a little bit, we will start with posing some general topic related questions to our panelist guests, and then they will answer them. But at the same time, you are all free to ask additional questions in the Q&A box. We will be keeping an eye on that Q&A box. Please try to keep those questions general, avoid personal information. And if we see like similar topics coming in, we might combine those and turn it into a broader question. And we'll try to get to as many of those. If they're on topic, we'll try to get to as many of those as we can. And please note that this session is being recorded. So a little bit about the hosts today. Dr. Ho, I'm going to ask you to please describe a little bit about the American Head and Neck Society, and then I'll describe a little bit about ThyCa.
Absolutely. Thanks, Daria. She and I will be co-hosting these sessions together. I, along with some of the others today, represent the American Head and Neck Society, or AHNS. The AHNS endocrine section, which is a subsection of the American Head and Neck Society, is an organization of head and neck surgeons, otherwise known as otolaryngologists, with a focus on expertise on thyroid and parathyroid surgery. For many of us, including especially the ones on the panel, it's our extreme focus. The AHNS strives to improve patient care, research, and education in this arena, and AHNS members work on surgical research and educational initiatives to push the frontiers of endocrine surgery. So we look forward to meeting with you guys as patients today and answering some of your questions.
Awesome. And I'll describe ThyCa, the Thyroid Cancer Survivors Association. We're a nonprofit organization, and we're really dedicated to the support, education, communication, everything that's needed for thyroid cancer survivors, or some people like to say warriors, their families and friends. And our mission, educate and support the global thyroid cancer community and invest in research. And of course, our vision would be a world free of thyroid cancer. So some introductions. I'll introduce myself. I'm Daria Gerald. I'm with ThyCa. I am an assistant chair on their board and a patient advocate. Gary Bloom, the executive director, is also with us this evening, but he does kind of plan to stay in the background. And then Dr. Ho, I'll toss it to you to introduce yourself and our wonderful panelists this evening.
Terrific. Thanks, Daria. My name is Alan Ho. I'm a professor of surgery at Cedars-Sinai Medical Center in Los Angeles. I'm an otolaryngologist or head and neck surgeon focused on endocrine surgery. My esteemed colleagues, they run the spectrum of thyroid cancer care. We have a good mix of folks that not only do surgery, but also perform things like biopsies, educate patients on nodules, and also take care of more advanced diseases, including ones that need radioiodine and beyond. First, we'll introduce Brendan Stack. He's a chair of Southern Illinois University School of Medicine in the Department of Otolaryngology Head and Neck Surgery. He's a ENT or head and neck surgeon. He also is our chair of the AHNS endocrine section, so is responsible for many of the initiatives that the AHNS has put forth. We also have Mary Sebelik. She is a professor of surgery at Emory in Atlanta. She's also an otolaryngologist head and neck surgeon. On the other end, on the endocrinology side, we have two esteemed colleagues. Wendy Sachs, she's my colleague at Cedars-Sinai Medical Center in Los Angeles. She's an endocrinologist focused on thyroid cancer. And also from University of Nebraska, Anupam Kotwal, who's an assistant professor of endocrinology, who also focuses on thyroid cancer in all aspects. So we have a very esteemed distribution of panelists who I think are well equipped to answer whatever questions might come across today, especially as we focus on the topic of early in the journey.
All right, excellent, thank you. So we're going to jump right in. So the first question is, if I find a lump on my neck, or maybe my doctor notices one, what happens next?
Why don't we start with maybe first on our list, usually an endocrinologist might come across this first when they're referred from a primary care physician. Could I ask Dr. Cotwall to perhaps begin on that? And if depending on what how he responds, we could also go to one of our surgeons, because many times we see these as well. So Anupam, do you have any initial thoughts on this particular type of question?
Sure. So yeah, this is a fairly common finding. So usually with this, I would say, go to your primary doctor. Most likely they would examine the neck. They would most likely get an ultrasound of the thyroid. That's the best imaging study to notice a lump in either the thyroid or the neck lymph nodes. And if there is a thyroid nodule or a lump, then there's also some hormone testing. So we want to make sure the thyroid hormone level is okay. But those are the usual next steps. And then based on that, we could kind of do a biopsy of either the nodule or a lymph node if that was the actual lump that was felt. So that's kind of the progression usually.
Excellent. Brendan, do you have anything else to add? I think this is definitely probably more thyroid focused, but I know it's kind of a more general question as well.
Well, no, I think as far as the current state of affairs, it's a good physical exam, pretty quickly to ultrasound. And ultrasound can not only describe the lesion in the thyroid, but all the other structures of the neck. That sometimes is forgotten, lymph nodes and other structures, and then proceed to biopsy. I was thinking of, as we were describing what was going on, how things have improved in the last 30 years. Because, not to confuse the audience, but 30 years ago, there was always arguments. Do we put people on thyroid hormone to see what happens with this? Or do we just watch it? Or do we give them a radioactive iodine scan? And on it went. So now we exist in a period of time where it's very straightforward. Ultrasound, biopsy, and diagnosis.
Excellent. Believe it or not, we have a couple questions that have already come in. And I'm going to paraphrase one of them and pose it to all of you. What if you've already had, half of your thyroid removed and you're doing follow-up ultrasound on the other half, and they find like a small nodule, but it's too small to be biopsied. And they say, we're just going to wait 6 months. We're going to do another ultrasound in 6 months. Is 6 months normal? Is there a normal waiting period for follow-ups like that when they see something on an ultrasound?
Maybe we'll ask that question of Wendy. She probably sees these sorts of patients and oftentimes has these questions posed to her. What do you think, Wendy?
Yeah, actually, we do tend to monitor thyroid nodules every 6 months when they're first initially found. And then as time goes on, if the nodules are stable in size, then we might extend that follow-up period to a year or 2 years, or maybe even 5 years. But initially, especially for nodules that may have of unclear ultrasound appearance, but yet don't need to be biopsied, we would wait 6 months. Thyroid nodules tend to grow very slowly if they're going to grow. And so 6 months seems like a good time period for us.
Excellent. Okay, I'm just going to give a shout out reminder to all the people that are tuned in. Feel free to put questions into the Q&A box. We are monitoring that, and as it makes sense, we will pose them and maybe paraphrase a little bit, but we'll try and get things answered for you. Okay, second question. Are the treatments the same for large nodules versus smaller nodules? I'm not sure how we would define large versus small, but maybe you all have some thoughts on that.
If that might be another endocrinologist question, especially one who follows these long term. So Anupam, do you have any thoughts about that kind of that kind of question that's being posed. These are very good questions, and ones are probably more common than even we are aware of. So this is great that you're able to explain this to the crowd.
Absolutely. So, nodules are pretty common now, especially with other imaging, CAT scans and all will incidentally find these. So usually those are nodules where the patient would not feel any symptoms, right? They would not feel any neck discomfort. So size is definitely one criteria we use. So, that before, I guess, moving to treatment, the first thing is knowing what it is. So we use the size, but also the way the nodule looks on the ultrasound. We, look at different characteristics, and with, we use the size as well as those characteristics to then say, well, is this something that needs a biopsy to know if there is cancer? It kind of depends on the risk of cancer in the nodule. Or is that something that can be followed, kind of similar to the previous question, something that can be watched in 6 to 12 months. So size is one of the criteria that we use for that. And then usually if sometimes cancers are very small, they could be followed or have a localized surgery. We can let our surgery colleagues comment on that. But if they're large and they have slightly more extensive surgery, if we are following nodules, so if say the nodule was benign on a biopsy or was small enough and didn't look suspicious, then usually the smaller ones we can follow somewhat less frequently. The larger ones or slightly more suspicious ones we would follow more frequently. So that's kind of the, using size along with the other characteristics on the ultrasound. So it's just not the size. But then there are, benign nodules or nodules that don't look suspicious can still cause people a lot of symptoms and trouble swallowing or hoarseness. And so if there is no cancer, they may still need surgery for that. Now there's some other options that are coming up, the non-surgical options. And then the third part is the hormone evaluation. So I would definitely want to not miss that. Usually larger nodules can be overactive, but sometimes even small ones can. So we do want to make sure we've checked the thyroid function test before kind of moving on with biopsy and things like that. So I guess a long way of saying is that not just the size, it's all the other things that we take into account to kind of do the diagnosis and then the treatment.
Someone's actually asking what is considered large for a thyroid nodule?
So yeah, that's a good question. And I'll let others maybe chime in too. We usually don't biopsy things that are less than a centimeter. So if any nodule is more than a centimeter and looks suspicious, it may need a biopsy. Large, I guess, it depends on, I would say more than 4 centimeter is considered large. So, if someone has a cancer of more than 4 centimeter, they almost always require whole of their thyroid gland taken out. Also, we know that more than a couple inches, so close to that 4 centimeter mark, is probably where patients may start having discomfort. But it depends, there may be people who have a 2 centimeter or a nodule that's 1 inch big and it's very superficial, or they have a slender neck and they may actually feel that and may be visible. So maybe somewhere around that 2 or 4 centimeter or more than that I would consider it as a large nodule.
Alan, can I make a comment?
Oh, of course, Brendan. Yes, this is a wide open. Go ahead.
I think I appreciate Dr. Cotwell's comments, and I agree with them. I think what's large is in the eye of the beholder, and I think he explained that very well, depending whether you're slender and how big it is and where it's located in the thyroid. But I think a key measurement that was brought up was 1 centimeter. And that's not necessarily the definition of what makes it large, but that seems to be a threshold measurement for when we start to be concerned enough to biopsy. Historically, a lot of millimeter lesions were being biopsied. They'd come back with all sorts of pathology diagnoses, and they could really confuse the patient, alarm the patient, confuse the doctors. And it resulted in people getting very aggressive therapy for very small tumors that perhaps were never going to cause the patient any problem. And in fact, if you look at all of the work that's been done out of Japan and at Sloan Kettering in New York and other places about observing small known thyroid cancers, 1 centimeter to 1.5 centimeters seems to be a dimension that the research has proven is a good limit for us to respect. So, again, 2 centimeters, 3 centimeters, 4 centimeters could all be the definition of a large one, but 1 centimeter, I think, is a very good measurement for patients to keep in mind when they're deciding, well, this needs to be biopsied or we can observe it over time.
Very good. Okay, again, that reminder to feel free to ask questions. I do see a couple have popped in, but I'm waiting for the right time in our content today to try and weave them in. The next question, what are the differences between a center of excellence with high volume thyroid cancer surgeons and versus say a community surgeon who might perform say 1 to 10 thyroidectomies a year?
Yeah, this is a very interesting, sometimes controversial, sometimes not question. I'm going to ask some of our surgeons to sort of weigh in. So I'll start with Mary Sebelik, and then I just want to let everyone else know we also have another panelist who has just joined, our esteemed guest Greg Randolph, who is an otolaryngologist, head and neck surgeon at Mass Eye and Ear at Harvard Medical School. He's our professor of surgery there and one of the real pioneers in thyroid and parathyroid surgery in our field. So we were really lucky to have him. But we'll let Mary speak first and then Greg chime in as well for this very, very relevant question. Go ahead, Mary.
Thank you. Thank you, Alan. I do think this is a really important question, and I would never denigrate a community surgeon who performs under 10 thyroidectomies because an individual surgeon can be quite skilled. However, it's important to look at surgical technique and surgical procedures kind of like an athletic endeavor. The more free throws you throw, the better you get at it. So that has a parallel to surgery. The more you do, the better you get at it. And the more you do, the more unusual cases you see. So it kind of makes logical sense that a high volume surgeon may have better outcomes, maybe shorter operative times, or better able to handle the unusual cases. And again, not to denigrate the community surgeon, but it's like athletic practice. You get better the more you do.
What do you think, Greg? Anything to add to that?
No, I think Mary described that beautifully. I think it's fair for the patient to talk to the physician surgeon, he or her, and ask for what is their volume, and also what are their rates of nerve paralysis and parathyroid injury. I think that's a fair discussion to be had, and if the patient senses some hesitancy in providing that information, that may be a warning sign. But I agree with Mary, you can have very good surgery in a lot of different settings, but it's fair for the patient to be empowered to ask those questions.
And Alan, can I just add something to that? I think that patients should, if they've been diagnosed with thyroid cancer and haven't yet seen an endocrinologist, I do think that seeing an endocrinologist preoperatively is important in order to assess for lymph node metastasis, make sure that patients have a lymph node mapping ultrasound prior to surgery so that the optimal surgery is performed.
It's a nice luxury and almost a necessity to have endocrinology weigh in because in a sense, after the surgery is done, the endocrinologist will be heavily involved. So it's nice to have that at the table before anything is decided. Does that sound about right, Wendy?
If, lymph nodes may not be assessed prior to surgery, and so that's a missed opportunity. Also, there's the discussion about potential thyroid hormone management, and that can be helpful to discuss preoperatively as well.
And to the point of this question about volume, I'm not going to focus on the surgeon, but the center. And I think this addresses Dr. Sachs' very smart comment, which is the integration of the endocrinologist as part of the team that's taking care of the patient. And if you go to a high volume center, which is often peopled by high volume surgeons, then you are going to get all of these amenities seamlessly woven into your care paradigm, and you will be very much the beneficiary of that, in my opinion.
Well put, well put.
Alan,
Anup,
if I can,
yes.
if I can comment on something Brendan said, you said team, and that's so important. I tell my patients that they have just joined a very elite team. They and their family are the head of the team. They have a surgeon on the team, and they have an endocrinologist on the team. And that's what it takes to treat thyroid cancer, is that good team. And so absolutely, Wendy, an endocrinologist needs to get involved very early in the journey.
Excellent. Just to spend one last second on this question, which again, I think is important, but it may also be site specific. So Anupam in Nebraska, do you see any differences between the kind of patients you see that come from the community versus the ones that are done maybe at your home institution? And has it affected the way you think, affected the way you've managed your patients?
Yeah, absolutely. I completely agree with the panel, just, in terms of having that more experienced team. And so, yeah, I mean, when we see patients sometimes from surgeons who kind of are more general and may not have as much experience or frequency of doing thyroid surgeries, there is, more numbers of, residual thyroid tissue or even side effects. So we know that, and there's also always that kind of the pre-surgical comprehensive neck ultrasound, including the lateral neck lymph nodes, is missed a lot of times. So I completely agree. Really kind of making the patients and their families feel empowered to ask those questions. And fortunately now with surgical expertise, the numbers of I guess high volume surgeons are growing. So at least at our institution, we have 5 high volume surgeons who are doing thyroid surgeries, so we're able to offer that. Nebraska is pretty wide, so patients do sometimes have to travel quite a bit, but yeah, I agree with because surgery is so the quality of the surgery is so critical to thyroid cancer, not just at the outset, but even long term. We all know of small amount of tissue that's left behind, and then all the patient worry and things like that, and also side effects. So I completely agree with having patients ask that information of their team.
Yeah, perhaps the single most important question of this topic, right? Early in your thyroid cancer journey, choosing that surgeon, choosing that team, choosing that center. Yeah. Excellent. Daria, did you want to chime in with any other questions or move on?
There's a couple of things that have popped in that are, one is directly on topic. Is there a way to find out how many cases a surgeon or the center performs in a year? Is there a way to look that up, or do you ask?
Yeah, Greg, I don't know if you're still on, but was this ever, I felt like this was something that was considered or mounted either at the ATA or AHNS or maybe some of the other places. Has it ever been established to have something that's reputable or reliable?
Well, I think that's a moving target. There has been a number of research studies looking at absolute levels. I think you have to take that with a little grain of salt. One surgeon may need a certain volume to have expertise. One surgeon may need a different level, but the numbers range. I think it's important to say the more, the better, but as low as 25, as high as 100 have been proposed by various researchers in the US and Germany. I think we are looking at a focused practice designation and other ways of certifying, focusing on thyroid surgery. So I would say the exact number, there isn't a lot of data to support any one number, but I would say that if the surgeon has one of their major focuses as thyroid and parathyroid surgery, that would be a surrogate for expertise.
Yes, Brendan.
To the point that the questioner was asking where to go. And I totally agree with everything Greg said. We don't know what that magic number is, but if you want to look for a number, you could go to www.cms.gov, which would be the website for the Center for Medicare and Medicaid Services. And you would be able to get the number of surgeries done on Medicare patients by anyone who participates in Medicare, which is almost every doctor across the country. Now, you have to realize that those are Medicare patients. And some people's thyroid practice may be constituted of a lot of people under the age of 65, and they wouldn't be counted in that data. But it might give you an inkling of the volume of their practice.
That's a wonderful tip. I know, Derek, I've been to a number of ThyCa conferences, and I feel like every single one, a patient will stand up and say, why don't we have our own ThyCa list? But again, not even the ThyCa survivors will know the true number. But I think that Medicare website might be a good surrogate or a good approximation.
In fact, I can elaborate on that. It's called the public use files, and they've been in place now for I think over 10 years. It's a pretty hard database. Yeah, that's right. And it's a pretty hard database to get through, but it's free and open access to the public. And those are the two qualifications, is that this be a physician who is taking care of Medicare patients, and that the Medicare patients are getting this particular surgery by code. So I applaud the intent of the public use files, but boy, they can be hard to slog through. But that sort of number is publicly available.
So since this is a session called Early in Your Thyroid Cancer Journey, we do have kind of a really fundamental question, and I think we should ask it and answer it, because these are people that are early in the journey. And the question is, what is the difference between papillary and follicular thyroid cancer?
Golly, very much a fundamental one. Wendy, maybe we'll start with you.
Sure. Okay, so papillary and follicular thyroid cancers are both considered well-differentiated thyroid cancers. The difference between them is a pathologic change in their cellular structure. So papillary thyroid cancer has papillary formations when you look at it under a slide, and follicular thyroid cancer has changes to the follicular cells that are not in a papillary structure or pattern. So what does that really mean to the patient, though? These are two types of thyroid cancer. The papillary thyroid cancer is the most common type, and there are subtypes within that category. So about 85% of all thyroid cancers are differentiated are papillary, and then about 10 to 20% are follicular thyroid cancer. There are, within the category, these are generally treated very similarly with surgery, depending on the size. And both can be treated with radioactive iodine afterwards if it's indicated. There's some differences. The follicular thyroid cancers can be more aggressive when they have more vascular invasion, and the pathologist will indicate the amount of vascular invasion of a tumor. And when a follicular thyroid cancer has a high number of vessels that show the tumor, that is considered a widely invasive follicular thyroid cancer, and that tends to be a more aggressive type of thyroid cancer that can spread to, distant sites, more so than to lymph nodes. With papillary thyroid cancer, if it spreads, it tends to spread to neck lymph nodes. So that's a little bit of a difference in those two well-differentiated thyroid cancers.
we do have other questions that are coming in, and there's a couple that are around the topic of micrometastases in the lymph nodes. And they're a bit specific, but I want to try and maybe generalize them and ask, if they see this spread of microscopic, really small spread into the lymph nodes, does that necessarily indicate a change in treatment plan? Does it mean maybe radioactive iodine? And if one is positive for the BRAF V600E mutation, does that change any recommendations with regards to micrometastases?
Well, it's a really good question. As a surgeon, always wondering about whether we've missed a micrometastases or not, or finding them on the final path report is always a bit of a jolt. Maybe I'll start with maybe Brendan, because you're vastly experienced in these operations, and what you think about this idea of micrometastases, because I know our knowledge and our philosophy along these lines has evolved over time.
It has. I got the sense from the question that the questioner was sort of seeking like a magic size of a micrometastasis to a lymph node, which would be more concerning or less concerning. In my mind, it's not the size. By the way, by definition, it would be a micrometastasis if it was under 10 millimeters in greatest diameter. So let's just establish that. But in my mind, it's not so much whether it was 9 millimeters versus 3 millimeters, and that's going to make an impact. It's the number of lymph nodes that contain metastases. If you have 1 or 2 lymph nodes out of a really large sampling of lymph nodes that have a micrometastasis, odds are that's going to be a fairly indolent or easily less aggressive behaving tumor. And perhaps in patients that had 1 or 2 isolated micrometastasis in a few lymph nodes, they could forego any type of postoperative radioactive iodine. Now, if somebody had countless, the criteria of concern from the ATA guidelines would be more than 4 or 5 lymph nodes positive. That would then get me thinking about, what's the adequacy of the neck dissection that was performed, and what would be the benefit of adding postoperative radioactive iodine to the treatment plan for the patient. Now, we had sort of compacted, let me just unpack this a little bit in the question as far as molecular testing specific to the BRAF mutation. There are certain molecular tests that might return on the operative specimens or even come on a needle biopsy before surgery that could indicate a more aggressive behavior. So if a person was to have a larger number of lymph nodes and was to have a molecular mutation that portended a more aggressive behavior, these would be all factors that the surgeon and the endocrinologist, the treatment team, would take into consideration when discussing the benefits and perhaps even the dose of postoperative radioactive iodine that might be proposed.
Very good. Okay. Since we're trying to stay on topic with that early in the journey, how about this question? How long is a typical surgery, and what is the recovery period like?
Right. Mary, can we have you take that one?
I'm happy to. So very often with differentiated thyroid cancer, the patient factors and the tumor factors allow us a choice between whether one side or both sides of the thyroid are removed. And so that affects the time in surgery. It can be as short as 45 minutes to take out one side, or as long as a couple hours to take out both sides, depending upon the patient's anatomy and the challenges of the thyroid gland. There can be discovered deep to the thyroid gland lymph nodes that may not be as visible on an ultrasound or on scans until the thyroid is removed. So that certainly can add time to the surgery as well. And so the patient's family also needs to take into account that the patient will be away from their family for the time it takes to go off to sleep and the time it takes to wake up and go to the recovery room. And that can seem like an endless waiting time for a worried family member, but the surgery itself is pretty succinct. The recovery period, I ask my patients to avoid lifting more than 10 pounds for about 2 weeks. And that's to avoid putting any strain or muscular pull on their neck incision. But other than that, getting back to eating is very quick the evening of surgery and clearly the next morning. Getting back to getting up and walking and getting to the kitchen and going to the bathroom, all things that you would normally do, but minus strain and lifting, are things that a patient should get back to as quickly as possible. Further, I do advise my patients that they can drive as soon as they can turn their head with reasonable comfort, which could be the next day. So it is a surgery that can be recovered from relatively well, but there are some cautions in that first couple of weeks.
Well
Excellent.
put. I gotta say, it's really hard sometimes to predict how a surgery will go. Sometimes you can predict, and just because the surgery is longer doesn't mean that there's something went wrong or something is abnormal. And I've seen surgeries go very quickly, but then the patient has a really long recovery, and vice versa, right? It's very, very hard to predict that sort of condition. But everything Mary said is in general true for any of these particular situations. Now, Brendan, can you perhaps to be a little bit more concrete for this patient's question, describe how long it takes you to do a partial thyroidectomy, how long it takes you to do a total, how long to do one with a central neck dissection, and how long with a total thyroid with a lateral neck dissection? Like what are some averages that patients can keep in mind?
And again, I really appreciate the way Mary described the time, because there's the time of the surgery, but there's induction time, there's waking up or recovery time. And again, to the person waiting in the waiting room, they don't know how long all these different elements are taking. But I would say typically around 45 minutes for a lobe or half of thyroid, a little over an hour, maybe an hour and a half for a total. And then if you start getting neck dissection work involved, that can add time. A central neck dissection, perhaps in isolation, doesn't add a whole lot more time because it's a direct extension from the thyroid bed. But if you're adding a lateral neck dissection, that's probably going to add another hour. So if you take the numbers that I just gave you, total thyroidectomy with a central and lateral neck dissection, pretty soon you're up to 2.5 to 3 hours right there.
So the next question, and this might address some of what we're seeing in the Q&A box also. If radioactive iodine is being considered, do I need to worry about the risk of secondary cancers from the radioactive iodine? Is this a cause for concern? And there is a question that maybe we can weave in from one of the attendees that says, what are the side effects, if any, of radioactive iodine?
All right, Anupam, do you want to take on this or tackle this topic?
Sure. Yeah, well, so one thing, of course, you should be concerned about side effects of any kind of treatment you're getting. The secondary cancers from, at least most of the studies happen with higher doses, repeated doses when we get above like 300 millicuries, so almost never at the first one-time dose. Again, this, there are, for example, risk of hematologic malignancies or blood-related malignancies is a risk, but it's much smaller. So I usually kind of inform patients about benefit and risk, right? So when we know that radioactive iodine will significantly decrease the risk of the cancer coming back or spreading, then we say the benefit is clearly there. And that's why we use keep in mind the size of the cancer, whether there was spread or how many lymph nodes are involved to kind of make this decision that is radioactive iodine going to be more useful. And the second is like what the dose is. So the secondary malignancy would be much rarer, and benefit is almost outweighing the risk of that. But there are more common side effects. There's mouth dryness, there's taste alteration, saliva gland swelling or sialadenitis, which can happen soon after or even months or years later. And those are real risks. So, you know, I don't know, and I'll share, I think some others on the panel know this. I was diagnosed with differentiated thyroid cancer a year ago and got a total and a lateral neck dissection. So when I feel like the patients may find that information helpful, I sometimes share that. As far as radioactive iodine, you know, I kind of share like, yeah, my mouth is more dry now, but the benefit of the cancer, you know, it reducing the risk of cancer coming back is much more. So there are things that we could do, right? There's precautions to take, better dental hygiene and hydration and all of those things. But absolutely, I would, you know, and that's why now when we discuss the dosing or the benefit of radioiodine, we actually involve the patient's thoughts on it. And, you know, and is their livelihood dependent on, you know, the hydration of their mouth or something like that. But in most cases, we can come up with the idea that, yes, the benefit will be more than the risk. And most people will take that, take the benefit. So that's I guess, my thoughts on this.
Very good. Thanks for sharing. Wendy, anything else to add about RAI and its purported benefits and drawbacks?
No, I think Anupam really described the short-term and potentially very low risk for long-term complications from radioactive iodine. Maybe a couple of others would be for women who are nearing menopause. Sometimes it can push them into not getting their period again. And some people have a change in their menstrual cycle for a short period, maybe a few months after radioactive iodine. And, you know, in general, the American Thyroid Association does give us some guides to when to use radioactive iodine or not. But overall, there are scenarios where we don't have really good evidence that it's going to necessarily improve upon the use of radioactive iodine will improve upon an already excellent survival outcome. And we can't necessarily prove that it will decrease recurrence rates. So for those patients who are sort of in the middle, who we don't know that there's definitively a benefit to use radioiodine, that's where sort of those conversations come in of, well, you know, we're not really sure that this is going to improve your recurrence rate. Maybe we wait and continue to monitor you and do it at a later time. And then there's, the conversation, well, we're going to do this, we'd like to still do it because of the number of lymph nodes or extent of disease. So it definitely is a conversation that is between the physician and patient needs to be had.
There's a couple of questions that are on to this topic of radioactive iodine. One of them is assuming that you need to have the radioactive iodine, like that's already kind of part of the plan. How long is too long to wait? You know, like after you have your surgery, when is the optimum time to do the radioactive iodine? And if you need to wait, is that okay too?
Maybe Anupam, you can describe your experience and about the urgency.
Sure. Yeah. I mean, we know most of the benefit, you know, it's that 3 to 6 month mark. We try not to delay more than 6 months unless we have to, and we ideally want to get it done within 3 months. We at least wait 6 weeks after surgery, also for, you know, the healing to happen after surgery. Sometimes at that 6 week mark, 6 to 8 week mark, we're checking a tumor marker, which as Wendy was saying, it's patients who are kind of in between where the benefit may be there, or we're trying to decide the dose. that tumor marker at the 6 to 8 week mark may help. So I would say, I guess the ideal point is anywhere between that 6 weeks to 3 months. And if you can, don't delay it more than 6 months after surgery. That's what I would say.
So there's a couple of questions here that I'm going to try to combine that are about some variants. One of the questions is tall cell papillary thyroid cancer considered a follicular cancer? And then another question is asking, have we noted that the incidence of aggressive varieties such as tall or columnar cells is increasing?
Good question. Mary, I wonder if I could ask you, because you've been in practice a number of years, have you noticed a change?
Yes, I think that over the trajectory of my career, certainly practice patterns have changed in response to our knowing better how to take care of these. But I have seen an increase or a perceived increase in some of the variants that are more worrisome. And is that because we're better at looking for them, or are they truly increasing in incidence? But yeah, my perception at this end of my career is certainly that I'm seeing more bad ones than I used to. But I think we're better at looking for the bad ones.
Brendan, how about you? Have you can you think of a number of times as you progress in your career where you were surprised at the path report, or maybe less so?
So I've really got to agree with Mary on this. I mean, I certainly have a gut impression that I've been seeing more of those, but I'm also, like Mary and many others, Greg Randolph, are in a practice that concentrates those types of patients. So is that part of the reason I'm seeing more of them? Is the pathology community getting better at reading these out? Are they, instead of just calling it, oh, it's papillary, are they really going the extra mile to scrutinize the slides that they're looking at? Or are they sending off the slides for second opinions? I mean, there are lots of other factors that might be operating in the background, and the true increase in incidence, I don't have proof for other than just my impressions.
I would just add, I think there are a number of studies looking at incidence of, say, something that's absolutely undifferentiated, such as anaplastic thyroid cancer, and those are much harder for pathologists to ignore. I don't think that the incidence has risen as much as maybe our bias thinks they are. So I would say I agree with Brendan and Mary. The true incidence may not necessarily be different, maybe our perception. Any other questions, Daria, from the question and answer section? They look,
Yeah, there's a few more, and
yeah,
we're
about
down
10
to,
minutes. Yeah,
we're down to 10 minutes. Just a follow up on that one, is tall cell papillary considered a follicular cancer, or is it a papillary?
oh, I think I can answer that because that's a little bit more objective. Tall cell is considered a variant of papillary thyroid carcinoma, so it's a papillary based.
There's some questions on kind of the follow-up. Like if you've had your total thyroidectomy, you've had your radioactive iodine, what does follow-up look like? Is it a yearly ultrasound? Is it blood work? And then along those same lines, there's another question with regards to monitoring thyroglobulin. When is a number concerning if you've already had your total thyroidectomy and your radioactive iodine?
Yeah, those can be sometimes real head scratchers, those numbers. Why don't we start with Anupam on his typical surveillance regime, and then Wendy can talk about the enigma that can be thyroglobulin.
Sure. So mostly surveillance is, lab tests, the tumor markers, the thyroglobulin will get at the 6 to 8 week mark. And then at the 3 month mark, we'll get the thyroid hormone test to see if their dose is okay, as well as do an ultrasound in most cases. And then, so usually it's at that 3 month, 6 month, and then a year from surgery. And then yearly for the first 3 to 5 years, unless, something comes up before and we would do ultrasound sooner. There are times when there are, in small nodules or small lymph nodes that we're watching, so we'll watch them. every 6 months, but at least after the first 6 months, we don't have to do things sooner than a 6 to 12 month time period. For low risk, now we do find very small thyroid cancer. Sometimes they're incidentally found on surgery for other things or less than a centimeter. Those I usually wait to do an ultrasound at like 6 month mark. So it's usually not needed that early on, but the first surveillance is the usual surveillance.
Wendy, what do you think about thyroglobulin? I know it's a fairly routine and widely used test. Can you tell us about its advantages and also perhaps some of its pitfalls?
Right. So thyroglobulin, as you know, is a protein that's made by normal thyroid tissue as well as differentiated thyroid cancer. And if one has a total thyroidectomy, the thyroglobulin level should be very low. But it might not be undetectable unless one also has radioactive iodine. So radioactive iodine can then ablate any residual thyroid tissue to make for an undetectable thyroglobulin, which then is a nice tumor marker. So nowadays we're not doing as many total thyroidectomies. So some patients will have a thyroid cancer that's confined to one side of the thyroid and have that side removed, and then their thyroglobulin, of course, will be detectable and it becomes a less reliable marker for recurrence. I don't think that that's what's being asked in this question. I think you're asking if you've had surgery plus radioactive iodine and your thyroglobulin is still positive, what does that mean and what level is worrisome? So in general, the thyroglobulins these days are the assays are very sensitive. So they detect down to 0.1 level. And generally, when the thyroglobulin is under 0.2, we think that there is most likely no disease. Even up to a level of 2, there may be some either residual tissue or perhaps a lymph node or micrometastasis. When you get up to the 5 to 10 level after treatment, when the thyroglobulin is about 5 to 10, then we know that there's some lymph node disease in the neck, and we'll do imaging to try to find it. Again, trends are important in thyroglobulin. So if the thyroglobulin is detectable and it's trending up, then that rather than just the absolute number, that trend is maybe indicative of growth of either something in the thyroid bed or in a lymph node. But if the trend is stable, even with a detectable thyroglobulin, that's quite reassuring.
Alan, just one point, just for completeness sake, Dr. Sachs did a great job, is some of these patients may hear something about the concept of doubling time when they're talking about trends. And basically what that means is, over what period of time did that number double? Let's say 2 to 4 or 4 to 8 or what have you. And the shorter the doubling time, the more aggressive the increase is and the more likely you're going to need to intervene. But if you have a very flat, stable presence of thyroglobulin, you may have a doubling time measured in years, in which case that's very reassuring.
So we're getting down to the final few minutes here. I want to tell the audience that we're not going to be able to get to all the questions that are in here, but I have taken screen captures of them, and we'll see if we can maybe get some answers, some written answers, and weave that into the video that we'll publish later. One last question: does radioactive iodine target thyroid cancer that has metastasized to somewhere else?
Yeah, that's a good question. Wendy, do you mind answering that as well? I mean, I think there's a short answer and there's a more detailed one.
Right. So, well, we generally do treat distant metastasis with radioactive iodine. And in some cases, it is sensitive to radioactive iodine. However, there are situations where thyroid cancer has become or has developed a resistance mechanism to taking up the radioactive iodine. And then those metastases are called refractory to radioactive iodine.
There was a question. There was a question asking how often does that happen? How, like, what is the percentage of people that are radioactive iodine resistant?
So that's really hard to say. I don't have a percent number. Anupam, I don't know if you have a percent that you can give. I would say that the majority of thyroid cancers are iodine sensitive and do not spread to distant sites. So about 10% of thyroid cancers can spread to distant sites, and still they can be sensitive to iodine. So, but I don't really have an exact percent that becomes refractory.
I think those numbers are, and maybe we'll use this to sort of sum up this excellent session. Those numbers of patients who have those more exotic, extreme resistant cases are quite rare. At the end of the day, we understand that the vast majority of these cancers are highly treatable, highly curable, rarely spread, and are almost never lethal, right? I mean, these overall survival exceeds 98, 99% of cases. And that's important to note. The vast majority of these cases, to reassure the audience and all the ThyCa members out there, are very easy to manage. And we should also think back to question 2 and Mary's comment on free throw percentage. The more you shoot, the better you'll be. I took the opportunity to look up what the average NBA free throw percentage was, and it exceeds 80%. And the elite free throw percentage, free throw percentages are on the range of 82, 83. So if you're not near a center and you deal with a surgeon who doesn't do 1 million thyroids a year, it's okay, because the likelihood of you having one of those exotic, rare, difficult to treat cancers is unlikely, and you'll do well with any surgeon who gains your confidence and does at least some thyroidectomies every year. Wouldn't you say, Daria? I think that's a good way to kind of sum up early in the journey that now that patients are more informed and educated, that they can take this with them and most likely in most situations have an excellent result. Would you say?
I know I did. 27-year survivor, and my surgery was at a very small place in Iowa. So with a general surgeon, not even a head and neck surgeon, and here I still am. I want to thank everybody. What a great set of panelists. You all were awesome. And thank you to the audience for your thoughtful questions. I am sorry we didn't get to everything, but we'll see what we can do with some of what was posed, and maybe try and get something woven into the video that we'll post later. And a reminder that we have more of these events coming up. And the next one, if you want to mark your calendar, is Thursday, the 15th of June. So please mark your calendar.
We had a tremendous and very warm relationship between AHNS and ThyCa. I feel like every time we have one of these sessions, we learn from each other. And this is really where the rubber hits the road. I feel like rather than being behind our white coats or behind our facades, this is really where we can connect with our patients and do some real good. So we're very grateful to Gary and Daria and ThyCa for really helping making this happen.
And thank you to the American Head and Neck Society for hosting this with us and for sharing your valuable time. I mean, it's wonderful that you're sharing your time with us in the evening, after your long work days, to take questions from this very large audience.
I didn't have to coax these people to come too hard. So I know they're absolutely very busy, but yeah, it was an honor to serve on this panel with all of these wonderful participants and panelists. Thank you very much.
Fabulous. Good night,
Thanks so much,
everybody.
everyone.
Everybody be
Good
safe.
night.
Thank you.
Thank you.
I'd like to thank the doctors for taking the time to follow up with some answers to some of the questions that we were not able to get to. The first one, when is the optimal time for a completion thyroidectomy after a hemithyroidectomy? The conventional time frame for completion thyroidectomy has been within 1 to 2 weeks to avoid scarring that would make the second operation more difficult. However, this is a minor issue and scarring does not typically extend to the other side in a way that is dangerous. As such, waiting weeks or months later is typically fine as long as it does not delay later treatments such as radioactive iodine. In fact, waiting 2 to 3 months later could be better so that scarring has had time to settle down. That answer was courtesy of Dr. Ho. Next, also courtesy of Dr. Ho, how common is it for people to get hemithyroidectomies based on an inconclusive diagnosis from molecular testing to find that they did not have cancer? This answer is going to make use of an acronym. The letters are NIFTP, and it stands for non-invasive follicular thyroid neoplasm with papillary-like nuclear features. In the world of thyroid cancer, this is pronounced NIFTP. So the answer is, this depends on the molecular testing result. Based on the type of mutation found, there could be as low as a 30% risk of cancer or NIFTP, or as high as 90% or more risk of cancer or NIFTP. NIFTP is a lesion that used to be considered cancer, but is now downgraded to a non-cancer since it behaves very much unlike a cancer. However, a needle biopsy or molecular test cannot tell the difference between true cancer and NIFTP. Only surgery can tell. Therefore, the chance of cancer is always a bit lower than the molecular test result given. Courtesy of Dr. Kotwal, the next 2 questions. The answers come from him. If planning to get pregnant, how long do you need to wait after radioactive iodine? Is it safe to breastfeed after radioactive iodine? We recommend waiting at least 6 months after RAI if planning to get pregnant. It would be okay to breastfeed a baby resulting from a pregnancy begun after this post-RAI waiting period has passed if the patient isn't given another radioactive iodine treatment during the intervening period. It is not safe to breastfeed during radioactive iodine. A lactating woman should stop breastfeeding. The last question, is active surveillance an option for a small recurrent lymph node, less than a centimeter, that tests positive for differentiated thyroid cancer on biopsy, in other words, a fine needle aspiration, or a total thyroidectomy and RAI have already been performed? The answer here from Dr. Kotwal is yes, but also keep in mind that some non-surgical techniques like ethanol ablation and radiofrequency ablation can be considered in these cases. These discussions should occur in consultation with an expert team of thyroid cancer specialists comprised of a surgeon, endocrinologist, pathologist, and radiologist. Again, thank you to the doctors for following up during their busy schedules, and thank you everybody for tuning in today.